Update webinar. We are very fortunate to have Dr. Lisa Giles with us. I also wanted to mention happy Groundhog Day to everybody. I know it kind of feels like Groundhog Year again here, but here we are. And so COVID keeps providing, and we're very lucky to have Dr. Lisa Giles with us. For those of you who know Lisa, she's a wonderful colleague. She is trained in pediatrics, psychiatry, and child psychiatry, and is an associate professor, as you see, of pediatrics and psychiatry at the University of Utah, and medical director of pediatric behavioral health at Primary Children's Hospital. I am lucky enough to have Lisa support our clinic with our mental health integration model, and so I'm fortunate to be able to interact with her quite a bit. Welcome, Lisa. Great to have you here.
Thank you.
All right. And to the group, just as a reminder, we love to have your comments and questions in the chat. As you all know, even before COVID, we were feeling a rise in mental health concerns in our community with children and youth. And COVID has impacted that. I think those of us who live in our offices feel that every day. And so with that in mind, Lisa, I know you've got some things to share with us. And as we go through that, again, feel free to put questions in the chat. We want to be able to have that conversation as we go. So over to you, Lisa.
All right. Well, thank you. I'm assuming you can hear me okay?
Yes, can hear you great.
Fantastic. So yeah, really, as Neil said, I thought, I'd kind of give the update. Again, it's the Groundhog Year for the second year in a row of kind of what do we know about the impact of COVID on pediatric mental health? And then we'll take a little break, have some discussion, and then hopefully give some practical responses to, okay, fine, but what do I do about it? So, for anyone that's been aware, there have been some really big announcements around youth mental health over these last 6 months. In October, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Health Association all declared a national emergency in children's mental health. And then, of course, in December, the U.S. Surgeon General issued an advisory out about youth mental health and really a call to action on all of this. And so we know that, wow, this is really at the forefront. Question, of course, being what's going on here? And I would argue, I think we have two main things going on that we'll talk about. One is a lot of just pre-COVID mental health concerns that were continuing to grow. And so you already had this trend of just increasing mental health concerns. And then COVID just becomes that converging factor, if you will, that just kind of really brought all this to the forefront. So again, if we look at what do we know even before COVID, by 2019, 1 in 5 children have been diagnosed with some sort of mental, emotional, developmental, or behavioral disorder. So really large numbers if we're talking, 20%. We also have the Youth Risk Behavioral Survey that's given to high school students, and students 6th, 8th, 10th, and 12th, that looks at kind of all sorts of different behaviors and mental health illness. And we know from that report that, again, over this decade prior to COVID even hitting, that increase in students that report feelings of sadness or hopelessness increased by 40% in the course of that decade, to the point of now you're seeing almost 33% of high school students are reporting feeling that. Same sort of thing around suicidal behavior, seen a significant increase over the last decade in students who seriously considered attempting suicide. And that same trend is similar for those that had a plan or actually did attempt suicide over the previous decade. So again, a lot of suggestions that, hey, we already are in this continual trend moving up and up. Certainly this is really similar graph line to like what we see at Primary Children's in the emergency room, for example. We've seen a consistent 5 to 10% increase year after year of the number of kids presenting in crisis to the emergency room. So then, of course, what happens after COVID hits? And, there's all sorts of studies out there. I mean, I picked a very few handful of all the studies out there that report these self-reports of increased symptoms of depression, anxiety, stress during this prolonged pandemic. So these are two examples of snapshots of surveys and studies that were done early in the pandemic. So this is April of 2020. Already folks are saying, hey, this is causing a significant stress. The JAMA Peds article that Table 1 comes from showed that kids, in particular were endorsing, that you had almost 20% of kids endorsing depressive symptoms and 18% endorsing anxiety symptoms, which is higher than some of those general populations. So already early on, there was a sense of this was stressful, right? And then those numbers certainly didn't change. So then by the fall of 2020, we've got, reports again of parents reporting that, hey, overall, my kids are really struggling with everything that's going on, all these elevated symptoms of that. There was then a JAMA Peds article that came out last summer in August of 2021 that really compiled all of these studies that had been done to suggest that, yes, really, we were looking at 25% of youth that were experiencing elevated depression symptoms and at least 20% clinically, significant anxiety symptoms. And so lots of this evidence of just people feeling distress. There's also the data that, again, helped drive some of the national emergency and the Surgeon General's advisory around mental health related ED visits. Now, it's interesting in this bottom slide, this is the proportion of mental health related ED visits. And this is what really made the headlines, if you will, that the proportion of mental health ED visits increased by about 30% in 2020 compared to 2019. It is important to keep that in context, I will say, by knowing that pediatric ED visits overall in 2020 decreased. And so it was that proportion of mental health visits that significantly increased. And so the visit, or the chart above that, this top chart really looked at the overall total number of visits. And as you can see, 2020 started out really high. As the pandemic hit, there was obviously then that, shelter in place and decreased health-seeking behaviors. So ED visits were significantly down and then kind of began to get back to kind of where they were. Although then the CDC also came out in just the end of 2021 and looked at some of those 2021 numbers and found that like last spring, so February, March of 2021, ED visits among girls in particular for suicide attempts increased dramatically in that period compared to that 2019 period. Although again, you have to remember that 2020, that period was also increased. So anyway, numbers, I don't want to, get everyone caught up in the numbers, but I think again, it does speak to kind of these two trends, one of overall increased volumes going on, and then certainly this increased attention to mental health, that the proportion of those ED visits had significantly improved or had significantly increased. So what does all this mean? What are all these possible stressors, all these possible factors of why COVID may be driving some increased visits to the emergency room and increased symptoms of depression and anxiety and increased angst and distress overall? There's probably multiple factors for this. There's probably multiple things going on. Certainly one of the big ones is just this loss of routine. So lack of structure, these changes in routine, especially you think early on in the pandemic, right, when kids were really at home. And some kids have remained at home and done remote learning for long periods of time. And so really, understanding what does all that mean? to have lost that routine and structure. And there's all sorts of studies that look at, how sleep has been disrupted during the pandemic and what does that mean for adolescents. Certainly social isolation is an issue, although it is interesting. There's a whole bunch of handful of studies now that have looked at some of the challenges, during quote lockdown. There's this study from the UK that actually showed that yes, people were really stressed at the beginning of a prolonged lockdown period, but then actually ended up resolving pretty quickly and being resilient and doing pretty well once you kind of get used to that new routine. A recent study that just came out talked about, some of the impacts on kids that have done remote learning for longer. And again, population-wise, kids have struggled more with remote learning, but there's definitely a subset of kids that have actually done better with remote learning. And so there's a lot of kind of mixed stuff going on there. But again, we can assume these things are stressful, right? And then certainly just the distress in general, right? Everyone's level of distress is higher. And, it's not just the, COVID illness itself, but kind of the divisiveness around mask wearing and the divisiveness around, all these things that, again, just leads to that level of distress. Economic concerns and hardships, fortunately, Utah seemed a little bit more protected in that area than other parts of the country, but definitely we have good evidence from other times of recession and depression that adults' mental health kind of suffers first when there's economic hardships, and then youth mental health follows shortly thereafter. There's the illness itself and the treatment, and certainly we know we can get medical PTSD and medical trauma from being sick or watching loved ones be really sick, and that disruption and the constant disruption back and forth. There are reports of increased sexual and physical abuse that have been occurring, during different periods of lockdown or different periods of the pandemic. A lot of kids with pre-existing mental illness lost a lot of resources and support, especially kind of in those early 2020 years. I think specifically of kids with autism who were getting, a lot of in-home ABA support and other things that really been on hold for a period of time. Grief and loss, as we'll talk more about.
Lisa, just for a second, really quick,
trauma of all of that.
Could we remind,
I think it's important, and
everybody,
I'd be remiss to not talk about that grief and loss. That the Journal of Pediatrics in December, so again, this is not an up-to-date number now, but in December published this article, talking about the more than 140,000 kids in the US that have experienced the death of a parent or grandparent from COVID. And we know that's much disproportionately higher in children with racial and ethnic minority families. And so that's got to have a significant impact on health as well. And then there's interesting, if you start wanting to talk about the neuropsych and cognitive sequelae from COVID, and this idea of, are there also, not only are there all these psychosocial stressors that have come from COVID, but are there direct kind of biological triggers of the virus itself that could have some neuropsych manifestations? Certainly there's adult data out there to suggest both kind of acute and longer term neuropsych disorders and cognitive problems. And there's theories about cytokine pathways and some other things that we've seen with other viral illnesses that can exacerbate some psychiatric stuff. At this point, there's still pretty limited data in pediatrics. Again, handful of some case reports to suggest, there may be some, with the brain fog and some cognitive challenges and those sorts of things. But certainly in pediatrics, we've seen a lot less of kind of acute encephalitis or other things that have created acute psychiatric issues. So then that really leads to this question of kind of long COVID, right? And what is the relationship associated there? And I would argue that, again, in the pediatric literature, it still seems really limited. We still don't know a whole lot about what this means for pediatrics. This was a study that was just published out of Denmark this month, that, again, an interesting heat map of kind of all of these kids potentially having some long COVID symptoms. And you can see in the kind of far right corner that, you know, these highest symptoms, you know, many of these are kind of in the headache realm, the fatigue realm, poor concentration realm. Although interesting, that's also, you know, some of the highest areas in the control group. So these things are common, right? Headache is common in adolescents, chronic fatigue, concentration problems. And so what does all this mean? I think we still have a lot to find out. But with that, I'm going to pause sharing for a minute now. Again, the goal was to paint a quick snapshot of kind of a review of the literature of kind of what we know of those impacts of COVID. And I think the bottom line is, yes, we know kids' mental health has already really been struggling, continues on this kind of upward trajectory, and then absolutely additional psychosocial stressors during this whole COVID era that are likely exacerbating it.
Perfect. I'm wondering, just for the group at large, you know, as a pediatrician myself, just in the community seeing patients, I mean, it was interesting to kind of feel, I guess, at the ground level, what this mental health angst was like for my population. I'm wondering if the group might enter into the chat. This is someone called this a waterfall activity. For those who are at a computer, don't put it in yet. I'm going to do a 5, 4, 3, 2, 1, hit enter. But if you want to type in something, what have you seen the most that you think is related to COVID and mental health, just in your own practice? And I'll give you just about 10, 20 seconds here to think about that and write something in. And then when I do my 5, 4, 3, 2, 1, we'll all hit enter at the same time, and we can kind of see. That's why they call it waterfall. It'll kind of waterfall through the chat, and we can kind of see what people are experiencing. And Lisa, I would be interested in your thoughts on that. I'm going to go ahead and enter mine here too really quickly. Okay, hopefully we have a number of people that are on the chat participating in our waterfall. So we'll hit enter in 5, 4, 3, 2, 1. Oh, interesting. Ooh. You see this coming through, Lisa, in the chat?
Yes.
So several really interesting things here. So I'm going to just jump up here and hit one. I've actually seen that with eating disorders. So Dr. Lau threw that in there. Is that something that you know has been reported? But I've seen that in my own population. I've seen more.
Yes. Yeah. So certainly anecdotally, we have seen that at Primary Children's. Well, I shouldn't even say anecdotally. We actually have the numbers to suggest the number of kids we admitted for medical stabilization of eating disorders before 2019 and then after, and then 2020 on, sort of thing. And we definitely seen increased, and it was kind of talked about on all the national listservs. And then there has been, I can't remember. I want to say it was Boston Children's, but I don't know, that actually published kind of their numbers to show that there was an increase in eating disorders. And who knows? There's theories about, certainly from a psychological standpoint, it would make sense that at times that you feel like you've lost control over other things, then eating disorders spike, because eating is kind of one thing that youth can control. So yeah, there's definitely at least plenty of anecdotal evidence to suggest that is true.
Yeah, very good. And then I see several in here related to anxiety. You talked about that as well. And I thought it was interesting how you said kind of the angst and the stress that the parents are feeling eventually kind of trickles down, because I think we saw an initial stress, but then I think we've seen this more pervasive kind of anxiety. I've seen that quite a bit in my clinic as well. Some good thoughts there. And then I think this one is interesting, sleep difficulties. Any thoughts about that one, Lisa? Have you seen that more in your patients?
Yeah, no, absolutely. And there are a handful of studies out there that have kind of quantified that and have shown that, yes, adolescent sleep difficulties that are kind of chronic anyway, but have definitely like exacerbated over the pandemic. I think we saw, a number of things kind of early on when like all schools were shut down and, so forth. You saw significant sleep-wake cycle disturbances, right? And you saw a significant increase in screen time. I mean, again, no kidding if you're doing school online, but even outside of schoolwork online, just overall a lot more screen time, a lot less physical activity, and kind of that worsening sleep cycle. Over time, as more and more kids have, been back to school and more routine, that seems to be improving some. Although again, it's still tied into sleep is so tied into anxiety and depression and all of this. And so as you see an increase of any of this, you also see those increased sleep problems.
Yeah. Great thought from Sarah Ting there. Thank you for that. Another one here that I think Michael Burton has here in the chat is anxiety over school performance. I mean, I think that fits in the overall anxiety bucket, but that's been a real thing for a lot of kids too, to try and navigate that. My own kids included, right?
No, interesting. And I think you've seen, certainly anecdotally, we've seen plenty of kids that, again, initially, when all of this started, there really was kind of almost this decrease of anxiety almost initially. Again, kids tend to be most anxious when they're in school, and school shut down, and there was pretty limited expectations for the remainder of that, school year in 2020. And so really, and there was kind of this like community bonding around what was going on, and everyone was in this together, and there was really this resiliency. And then this kind of like, and then when you have to return to real life, so kids that had been online for longer, then all of a sudden, once they have to go back in person and really try to start, living a real life again, then you saw, significant increases in anxiety. And I think it's, we tend to see those trends every year historically anyway, right? Like after school starts, about a month or two into the school year, we start seeing this increased anxiety and increased angst. And come February, March every year after kind of Christmas breaks over and we're back in school, we see this kind of increase. And I think that just really exacerbated with kids that had been online, lower expectations, and then all of a sudden kind of getting back to that, I think becomes really challenging.
Yeah, and I think Mark Valentine just threw something in there kind of related to that, increased interest in obtaining medication for ADD. As things kind of went that direction, I think I experienced that in clinic. That's a great comment, Mark.
Yeah.
I want to.
Yeah, and that really is intriguing. I don't know of any data on that for sure, but yeah, certainly anecdotally too. And I think, it was interesting. I don't know your guys' experience, but I heard from a lot of parents that were actually, having to sit with their kids, do homework and do schoolwork for the first time. And they were like, oh, they can't concentrate. They can't do this, whereas before it was off at school and they were just, in the whole context of everything going on.
Yeah, great comments there. I appreciate everybody doing that. I want to call out here, Diego Isledlo put in what you mentioned about the loss of routine, but connecting it here to chronic care for kids that have medically complex disease like diabetes or other things, and how, the impact of this mental health distress may have impacted other illnesses as well. So I know you do your consult clinic. I'm wondering if you've seen some of that as well, Lisa.
Yeah, no, I mean, absolutely. And, certainly we know kids with, chronic illness have been in general more affected, right? There's increased fear of severe COVID. So probably increased isolation and increased, stuff compared to otherwise healthy kids that, have less to worry about. And so I think there's that going on that's been challenging. I think just in general, access to medical care has been more of a challenge, right? And it's been a lot more has been done virtually than in person. And so, certainly, anecdotally, I've seen some of these kids with a lot of chronic uh, medical illnesses just get like the level of care, is kind of decreased. It's like, well, we haven't really followed up on that, and we haven't followed up on this, and just kind of overall that health maintenance has decreased. And so I think you see that going on. And then certainly, yes, we know there is that just profound relationship between stress and mental health and your physical health. And so as you're more stressed, all sorts of physical and biological markers increase and worsen.
Yeah, great comments. Great comments here too from Tim Duffy and Brooks Keeshan, just related to, when we see these increased requests for ADHD, anxious, depressed children can look like that too, with parents requesting those. So just the importance of really thinking through that. Great thoughts from the group. I want to call out what Miguel Canocal put in there too, just increased suicidality overall. Do you want to speak to that, Lisa?
Yeah. So again, I mean, we certainly have, evidence that those suicide attempts, suicidal ideation continues to kind of increased ED visits. Fortunately, in Utah, as we track the data, we have not seen an increase in youth suicide deaths, fortunately, at all. In fact, like those numbers, if you will, have really stabilized. They're still too high. We have work to do, but have really stabilized over the last 5 years and have stayed pretty stable. And so, I think it's important to make sure we're recognizing the nuance of all of this. Of yes, everyone is feeling more stressed, and we are reporting lots more symptoms, and yet our data really suggests that kind of the increase in suicidal ideation and the increase in suicide attempts is pretty consistent with the trend that was occurring before COVID as well. And so, keeping all of that in mind.
Great. Thanks for your thoughts there. One thing I did want to ask, and you mentioned this, just the number of kids that have lost a primary caregiver. There was that really powerful study. And I think all of us that are in clinic have had lots of patients have lost a grandparent or an aunt or an uncle, certainly. And even, I've got one little family where the dad died. He was in his 40s. And this is really hard. And the other piece to that, when we're talking about parents, impact on parents and caregivers, is I'm seeing a lot of parents that are really stressed and depressed and anxious. Maybe I don't know if there's a study about that, but we pick that up as community pediatricians, whether we're screening for it or just asking, how are you doing? I had a little girl with tummy pain come in, and it turns out the issue wasn't her stomach, as we all familiar with, but it was that dad was at home severely depressed and suicidal. So there's this piece too. I don't know if you have thoughts about kind of the family environment and the mental health of parents, if anybody's studied that.
Yeah, no, absolutely. I mean, that's a really significant thing. And so there are a handful of studies that do suggest, so again, a lot of those surveys that just are overall surveying the population about level of distress and depression and anxious symptoms, and then they break them down by, and how many of you are parents, and certainly the breakdown does suggest that especially single parents report much higher levels of distress. Again, probably no surprise.
Yeah.
But parents of really younger children express more distress. Again, lives have been probably disrupted more in some of those age groups. Mm-hmm. And so that definitely is. And then, yes, Neil, to your point, I think great point. We know that parental distress just filters down and becomes kids' distress. And I think anxiety more than anything is where we see that. So much of anxiety becomes modeling. And so if you have anxious parents, kids become really anxious.
Wonderful. I really appreciate your thoughts on that. I mean, it's certainly kind of the lived experience. So I appreciate getting your thoughts. Let's go back to your presentation, Lisa. We had a good time. I want to thank everyone who put things in the chat. There's a lot of great comments for those to just encourage people to kind of scroll through and read through those. Some good comments about sleep and anxiety and self-harm, and really appreciate people putting their thoughts in there. So Lisa, yeah, if you want to segue to thoughts about, what do we do? What are the resources as we're engaging with this on a day-to-day basis?
Yeah, no, absolutely. Because again, it's one thing for us all to talk and acknowledge, yeah, we're all seeing it, it's all there, but what do we do about it? I think first off, I want to point out that it is important to remember that youth are resilient, right? And so again, we talk about all the angst, we talk about all the increase, but the majority of kids are not having depression, or not having anxiety. Yes, it's a significant minority that we've got to address, but youth are resilient and they are overcoming, fantastic things. And you definitely see growth through all of this too. And so I think that's important to keep in mind. And then kind of, some of these overarching principles to remember that, again, that distress response can vary greatly. The importance of supportive parenting and caregiving in really buffering that stress response, back to our, discussion about that parental distress and the role that plays, the value of coping skills, and then really evidence-based interventions. So again, practically, what does all this mean? Well, first off, the importance of screening, and I don't want to spend too long going into this. We've certainly had other discussions about, what tools you can screen with, and we can have more of those discussions as needed. But really, the value of asking the questions and screening so that we know what's going on, right? And so whether, so we can screen for depression with a PHQ-A, we can screen with anxiety with a CAT-7, or a scared behavioral concerns with a Vanderbilt. And I think some of that gets at, Tim Duffy and Brooks and others were really raising that challenge of, hey, anxiety causes poor concentration, and how do we tease that out? And, really looking for those things. We can screen for pediatric traumatic stress. Dr. Keeshan and company have done a fantastic job of creating a pediatric traumatic stress care process model for the primary care setting that begins, again, with screening. Let's look and see if kids are being traumatized. There's certainly plenty of going on that can be traumatizing. Again, most kids are resilient and it's all good, but not for everyone. And so recognizing that trauma, which again is another real mimic of ADHD symptoms, is trauma. And, obviously ongoing suicidal screening. So if you're doing a PHQ and you're looking at that question number 9 and then following up with a Columbia to better understand that, but making sure that we're screening. Because then once you screen, then you can have a better idea of what to do, right? And I'm a huge fan of this idea of really our interventions should be based on kind of that triage and severity. And even if we don't quite understand precisely diagnostically what's going on yet, I think often that the severity becomes more important than the diagnosis, if that makes sense, in terms of what are our interventions going to be. And so to think of it through that lens, we look at, okay, those kids that are really severely impaired, that are clearly not functioning, right? You're going to need additional help. We're going to need to get them additional resources. We really are going to need to really assess, really figure out diagnostically what's going on. We're going to need to refer for evidence-based therapy. And we'll talk more about how to do that, because I know that's easier said than done at times. But we know we really are going to need to get them into therapy. We may need to give medications if needed. We may need to, refer to psychiatry, consult a friend. And again, I recognize these things are easier said than done. And so at the end, I'm going to talk about some ways to help do those things. But again, in some ways, those kids that are really severely impacted, you're going to need to get help, and you're going to help get them help. But for the kids where it's more mild and even moderate impairment, there actually is a lot that can be done in the primary care setting. And we'll talk about just a few of these. But I think, again, it's the importance of really encouraging supportive parenting. We'll talk in a second a little more what that can look like. And then really just providing education about what's going on, what those next steps are going to be, and what the follow-up is. So a great example of this in the GLAD PC guidelines, which are the guidelines for the treatment of adolescent depression in primary care, it really walks through how in mild and even kind of some moderate depression, there's really good evidence that just having a talk with your primary care doc who's able to say, hey, look, I think I know what's going on. This is depression. There's a few things I want you to do, and I'm going to see you back in follow-up. That alone can be very helpful, and often that alone can be the intervention that's needed for mild depression. Again, there are these brief targeted interventions that can be done even in a super, super quick primary care visit with some follow-up in place. And so again, with depression, if we're sticking on that line, the idea of like behavioral activation, right? Of just, hey, can we make a plan to get up and walk outside every day? Can we, like, what are you going to do to get out of bed? How are we going to do stuff? I want you to play with make a make a date with a friend this week. Go do something fun on Friday night. That's your goal. How do we do that behavioral activation in a simple way? There's interventions like, encouraging journaling, encouraging exercise. Sleep becomes big for all of these, right? If sleep's the problem, how do I help provide a targeted intervention? Give some sleep hygiene education. Let's refer to some mindfulness resources, things that we know can make a difference. If it's more acting out, externalizing behaviors, again, a lot of that's going to come down to parenting strategies. And, are there recommendations that you can work on in a really quick visit that can make a difference? We talk about supportive parenting strategies, specifically, this can be simple things like just encouraging that increased positive parent-child interaction of just, hey, can we have one-on-one time every day? That is just planned time, and again, this is not where I'm going to drill you about how you're doing in school and, what's going on. I think of some of my conversations with my teenagers last night. That's not this, but this is fun activities, right? This is talking about something they want to talk about. Let's talk about you're passionate about skiing or, whatever it is. And then again, always easier said than done. I speak of this as I can give this advice and not always follow it as soon as I get home, but, using that calm voice, that calm facial expression with giving consequences. There's all sorts of good resources. These were all resources that were pulled early on in the pandemic that people got together, but they still are very pertinent and really can talk about the importance of kind of these parenting tips and parenting that. The brief targeted interventions, when it's like, again, these externalizing behavioral challenges, again, for younger kids, it's how do we really focus on the positive behaviors and have a clear discipline technique in place. For your older adolescents, it's how do we make sure that we're validating teenagers' feelings and having that, again, that positive communication, and that we're making the rules and consequences ahead of time so there's shared decision over that. And it's not a reactive, I'm grounding you for the rest of your life sort of thing when that happens. So there are those interventions that can make a difference on on just kind of your basic day-to-day level. And then obviously the moderate impairments in between, right? So again, education support, some brief targeted interventions while we're waiting to get into therapy or those sorts of things. And maybe we'll need medication after we've tried therapy. But again, we've got the mild interventions or the mild impairment, moderate and severe, and then we respond appropriately. So now I want to end with, again, okay, Dr. Giles, this all sounds great. And okay, I recognize, a kid has some significant generalized anxiety disorder, needs to get into CBT, but how do I make that happen, right? How do I get kids the resources that they need when they need more resources? So one number I want to make sure that you're absolutely aware of is this is Primary Children's Assessment Referral and Consultation Service line. And this is the phone number. This is a phone number you can give to families to call, or you from your office can call. There is one of those like extensions if you're, calling from a medical office that will get you through. The folks through the ARCs ARCS for short, Assessment Referral Consultation Service. They have created a significant database all throughout the state. So this is not just kind of Salt Lake Valley, but this is all throughout the state of really what are the local resources? What do folks do? So community mental health agencies, private practice folks, all of these folks, what do they do? What services do they provide? What insurances take what? So forth. And so as you or families call, they're really good at saying, at figuring out, okay, insurance, where you live, and, what's the presenting problem, or what services are we looking at? And therefore, let me get you some resources into that. They do a phone triage of sorts to really kind of help understand what the needs are, be able to get kids to that right placement at the right time. If things are like really confusing and like the phone triage doesn't tell us enough, then they can bring kids in or do a telehealth eval to kind of help sort that out a little more. So that's a resource that I think every pediatrician should be aware of and using to, again, get kids right care. I use it all the time because I can't keep track of what therapists are doing where, and especially if I'm looking, I need to find someone in Price, Utah who can these sorts of things. So fantastic service. Another really helpful service that, again, is available throughout most of the state. This is a state-run program called the Stabilization and Mobile Response. That, again, exists in most of our counties. There's still a few counties. Tooele doesn't yet have one, and there are a few other counties throughout the state that don't, but most of the North does, most of the Southwest does, Salt Lake does. Utah County is rolling it out kind of as we speak, and that will expand to the eastern part of the state as well. The Stabilization and Mobile Response is a team of, and it usually includes like a licensed social worker or a social work support who can come into the home and help stabilize a crisis, or, kind of help stabilize the angst and the challenges that occur. So really fantastic when there's lots of parent-child conflict going on, when there's just that like angst. Can be really helpful in helping us bridge, until maybe we get into some other services or that, because it can happen like now. So again, another resource I think is really important to be aware of. And then the final resource. Oh yeah.
Oh, just on that one, I just have a quick anecdote. That same little girl that I mentioned with the tummy pain, who had the dad at home who was suicidal, the family, as I talked about it, I could see was really, really, really distressed. And so what I didn't realize I could do, I think you told me I could do, just had the mom who was at that visit call the number right there in clinic, and they set up a time to come out to the family's home. I think it ended up not being that afternoon, but the next day. That's just what worked out best for the family. But then it was interesting. They did come and they help address the stress of the kids, but they also helped the dad get connected into care, which was really awesome. I actually saw him a couple weeks later at another visit with the kids, and he was doing better. So I don't know. I think it's a great alternative to kind of emergency department. The team really does go out to the homes, and it can. I don't think it's the panacea. I'm not saying that, but my own experience is it's pretty darn good.
Yeah, absolutely. And then the last resource I want everyone to be aware of is the consultation access link line to Utah Psychiatry, or known as Call Up. So again, this is a state-funded service that's free to any primary care provider, that to call allows you to call and talk to a child psychiatrist. The child psychiatrists are available 12 to 4:30, Monday through Friday. You can also go to the website and just say, hey, can someone call me at this time, and fill out a consultation there. We're working on kind of making it perhaps a little more real time and available to do electronically. But again, so often it's, hey, as a primary care doc, you're feeling pretty comfortable to this level, but you just would like this little, is it reasonable to go to this medication? How high do I go on this medication? What is the next step I should do? And so, and often, again, we know wait lists to get into child psychiatrists can be quite lengthy at times. But hey, these are all the steps we could be taking until then or instead of then, or those sorts of things. And so again, fantastic resource to be aware of, that again, you can phone a friend when needed.
Yeah, that's a great one. I'd be interested in the chat of if anyone has used the call up service and could mention just briefly what their experience was. I know it is something that has been funded by our state legislature, if I understand right, Lisa, and it is a wonderful service. It's been done in other states, and it's been shown to really make a difference. So the call up is really great. Another great service. Oh, here's a question for you from Miguel Canoco. Is call up peds and adults both?
So it is with some nuances. So the direct service to talk to a child psychiatrist, 12 to 4:30 every day is available up to age 24. So kind of that, young adult and pediatric realm. But they do have adult psychiatrists that are available. It's just not same day service. So if you call with an adult question, leave the question, an adult psychiatrist will get back to you within 24, 48 business hours.
Great. Thanks, Lisa. Here's a comment from Joseph Johnson about call-up. I'm guessing that it works great. Use them to find help for counselors for patients as well. I wanted to mention on the ARCS line that you had up there too, I had a little eating disorder, 7-year-old with eating disorder. That was something that was over my head. I mean, it was really concerning. And I don't know what providers do 7-year-olds with eating disorders. And so I was able to get the family connected with the ARCS team, that phone number that you had up there, 313-771-1711, or I can't remember what, something like that. And they don't provide that service. So it's important for people to know it's not just services that Primary Children's Behavioral Health provides. They'll connect to others. But they connected this family to someone pretty close to where they lived that could help this
That's actually
girl with
really
eating disorder. And it really made a difference. So I thought, again, hopefully these are great resources. We're getting, if just a reminder to go mute. It looks like Mark Sheffield might be not on mute. If you could mute, that would be great. Thank you there. Perfect. Okay. Oh, and then Bridget Hanna just put in the chat. This is important as well. The CME credit code is 20016. I'll repeat that to for those who might be listening. The claim credit code, some alliteration there, is 20016. All right, other questions or experiences that folks may have had? Comment
hey, Dr.
here
Davis.
from Brooks Keeshan. Yes.
Sorry, I have a question. I'm just on my cell phone, but this is Vanessa with Red Rock Peds. So as we're implementing, the trauma and all the different layers that we've added with, the depression screening, anxiety screening, and now this trauma, I was wondering if the pediatric service line through Primary Children's or otherwise has anything that we can kind of send for education for parents to work with their children's at home. So like when I was thinking the other day that I wanted to meet with our dietitian and our mental health provider and our pediatricians and ask, can we rotate like a quarterly education where once a month we're talking about maybe the dietary benefits of eating, a whole foods diet or good foods. And then maybe the next session is on meditation and belly breathing. And then the next month we talk about sleep habits and how to kind of capture that. And then we rotate those three educations every quarter so that we can enroll families into it. So because when they leave the office, I think we just want to give them one more additional layer of that education and homework to do at home, or maybe they don't require getting in with a therapist, but can do some homework with their child to kind of develop these healthy habits. And I know in the adult world, they have those type of education modules that we can send to families, if they have, different ailments. And I'm wondering, do we have that for peds? Are we working on that? Is that something that maybe we could do? Do you want us to do it at a local level and just kind of talk about it that way, or any help that way?
That's a great point, Vanessa. Because yes, I mean, I would agree overall. Yes, I love that strategy. And I think that's helpful and really important that, hey, we're doing, we're providing some education about the brief intervention in the office, and I'm sending you home with something concrete to do. Excuse me. So we do not have any, I would say at this point, like Primary Children's does not have any, formal kind of modules like that. Love the idea, and maybe we should start developing. There are a lot of resources out there already. Brooks in the chat provided the link to the traumatic stress care process model that really does have some great resource links in there that again are some good links to either, print out a page to give to the family or provide the family with a link for some of those things exactly you talked about, Vanessa, in terms of like some mindfulness work, some sleep hygiene sort of stuff. So I think that's a good kind of immediate resource. There are a few helpful kind of let's talk about handouts for families that again can get some of that going. But nothing that like again has been like formalized, all put together to say this is what it is. That's actually a fantastic idea to do this. I would say at this point, I would pull together your resources on your own and be doing that. But I like the idea
that
for sure.
That prescription pad that Brooks is talking about is super helpful for when they leave the office. I agree. But I'm thinking if we took it another step and say, I'm enrolling you in this Zoom link that we're going to send you, in the month of January, that's going to be specific to sleep hygiene. And we're going to have a provider present on it and you can ask questions. And then the next month, we're now sending you the link to this, just to kind of keep it in the forefront of their mind. Because I think when they're in the office, it can be overwhelming. They leave. Did I lose that paper that had those links that you gave me? So I don't know. It's just a thought that I had to kind of continue it on an additional level to help those parents help their children.
I love that idea. I really do.
So do I. And thank you, Vanessa, for all your leadership down there in St. George to work on connecting resources. It's much appreciated. I might mention just one thing that I have noticed to be really useful in that situation is a little mindfulness, super short mindfulness skill thing in the office. And what I have found especially effective there is asking the kids if they have learned about any breathing at school. And almost always now, the kids will say, yeah, oh yeah, I learned about taking deep breaths at school. And I've had several kids teach me different techniques that they learned at school about when they get those feelings of stress, this is what I can do. They just kind of forget that's what it's for. But I think that's important. And frankly, right now in our political social environment, there's some pushback, and I think it's mostly misunderstanding in our community about what social emotional learning is. But it's that kind of thing. And thankfully in schools, kids are getting some of those skills. And I found it really helpful just to ask them what they have learned. And then a lot of times the parents are like, oh, I didn't know she knew how to do that. And oh, we can do that together. Anyway, that's just another little thing. So I do want to call out Miguel Canocal. Thank you, Miguel, for putting in the chat just a reminder about those resources, those 3 key resources that Dr. Giles just talked about here with the ARCS line, the stabilization and mobile response, and then the call-up service. So very good. I also wanted to call out up in the chat further up, there were some great comments about the screening. Toby Cox put something in very, very helpful as we were thinking through how can you tell, what's the source of some of the maybe concentration issues or other things. Just he mentioned that he frequently has kids coming in with inattention who just happen to be in a high range on the GAD-7, and it's very helpful to convince parents that a stimulant is not always the answer. So I hope you're scrolling through the chat. Some great thoughts from Kelly Brinkerhoff as well. Just really important things about sexual and physical abuse being increased, and being prepared to sensitively discuss those things and connect to the right resources there too. So great comments in the chat. Lisa, we'll give you the last word here as we wrap up. Is there anything else you would want to share with the community of pediatric providers as we lean in on this mental health challenges in our community?
I would probably just say thank you for all you do. I mean, you guys really are the front line for so much of this, right? And, as you read through that Surgeon General's advisory on mental health crisis and all this sort of stuff, it becomes this like call to action. And as primary care providers, you guys really are the front line. And I think it's been really exciting to watch, I don't know, over the last 5 years, 10 years, whatever it's been, like really watch that like acceptance and just see so many practices, develop really good strategies for screening and triaging and how are we doing these things and being able to provide these interventions, recognizing that, again, you are the front lines. This is like the morbidity of youth these days is mental health. And this is what we've got to figure out how to manage. And so thank you for all you do.
Well, thank you, Lisa. It's been a privilege to talk with you this morning. What a great reminder too that you mentioned about how children are fundamentally resilient. And I think that was a nice heartening thing when you said that too. So thank you for your information, for your hopefulness. I think we all need that. Drive safely, everyone who's commuting on the road.